When the human race started to walk in the erect position, this had an influence on venous diseases of the lower limbs, resulting in the development of, among other, varicose veins. It was therefore necessary to find solutions, and that started, as we'll see, very early in the history of mankind. During the Egyptian period, varicose vein surgery was not performed. Veins must be respected as shown by the Ebers papyrus. Hippocrates recognized the correlation between varicose veins and ulceration of the leg, but without surgical action on the vein. Then, from antiquity, varicose vein surgery appeared with more and more detailed writing, but often with mutilating resection. Ambroise Poiré, that you can see on the picture, a French army surgeon, described the ligation of the great saphenous vein in a tite. The 19th century saw few changes with, for example, in the central image, an excision of the great saphenous vein by Madelung, the procedure still being mutilating. It was in the 20th century that things evolved with the appearance of the stripper, and around the 50s, complete stripping became more popular. Concomitantly or sequentially with the treatment of truncal insufficiency, residual varicosities can be treated by phlebectomy. Phlebectomy was first described by Aurelius Cornelius Celsus and was reinvented a little over 40 years ago by Robert Muller. Robert Linton was the first to describe this operation of subfascial ligation of the medial lower leg communicating veins in the 1938, and Coquet described the extrafascial ligation of perforating vein in 1953. During the 80s, the technique of subfascial endoscopic perforator surgery was developed. It should be noted that since antiquity we see different needles and syringes appeared. This has not ceased to evolve until today. From the 80s, ultrasound is more and more used, with two essential contributions in phlebology, which are still relevant today. First of all, to establish the whole pathological venous network with identification of sources of reflux and connection with varicose veins, and ultrasound guidance. The first forms of sclerosing agent in foam form were described in 1930. The 90s allow an evolution of standardization of practices, as you can see. The two detergent sclerosing agents for foaming are polylocanon and sodium tetradecyl sulfate. In the 90s, there was a large development of techniques to standardize foam manufacturing. From the 50s, the syringes are reusable and sterilizable, and iodine or mercury are fortunately no longer used as sclerosing agent. It is very important to remember that ultrasound-guided sclerotherapy was the first technique to oppose surgery, the gold standard at the time for the treatment of varicose vein. Today we have two main types of treatment for varicose veins. First of all, the technique known as thermal tumescent ablation treatment. There are many devices whose objectives remain the same. The most widespread and widely used treatment are radiofrequency and laser treatment. The two other techniques, less widespread, are also used. Endovenous microwave ablation, whose principle is the one used for hepatocellular and renal resection, and steam, whose principle is to apply the caloric energy through the supply of steam. And the second types of techniques are non-thermal non-tumescence ablation treatment. Sclerotherapy remains the first known technique of this category. I'm not going back on it. MOCA, or mechanical endovenous ablation, was introduced in 2010. The aim is to combine mechanical abrasion of the vein wall and simultaneous injection of sclerosant. Cyanoacrylate glue is more recent with FDA approval in 2015. Cyanoacrylate glue has long been used in the management of intracranial arteriovenous malformation, for examples. Now, used for varicose vein, the working principle of the glue is quick polymerization upon contact with blood and high viscosity. These properties help prevent embolization. Today, it is the reign of thermal ablation. Surgery is making time. Radiofrequency ablation and endovenous laser ablation appear to have the same efficacy. For the non-tumescence technique, the absence of tumescence is a comfort, but some of them struggle to be used very widely, and we have not yet mastered all their adverse events. Finally, in spite of all the research and development put in place by many companies, it is sclerotherapy that resists best. Even if it is not the best technique for saphenous veins, it remains irreplaceable for certain types of varicose veins, particularly recurrent varicose veins and C1 varicose veins. The surface laser not efficient enough and not versatile. Sclerotherapy in practice is the all-terrain technique. For the future, two axes of reflection, technology and strategy. For technology, there is the no tumescence, but often expensive, not always reimbursed, difficulty in supplanting thermal. Future developments are needed, for example, higher wavelengths, 1940 nanometers, new indication for ulcer perforators, new studies, etc. And techniques to treat the smallest varicose vein as an alternative to sclerotherapy, mini-fiber laser, hybrid techniques, other device improvement. The second point is strategy. There are some questions that we can and must think about. Which treatment criteria? Occlusion, quality of life? Both? What are the criteria for the choice of treatments? Cost, reimbursement, best technique? What to treat? What chronology? Complete trunk, tributaries, perforating? About recurrent varicose vein disease, sclerotherapy, but other alternative to come? For spider vein, foam sclerotherapy? In conclusion, we must keep in mind the goal, be minimal invasiveness but cure. And never forget that venous disease is by definition chronic.